the form, the shape is different between us. Sometimes it is such as this. Sometimes it is possible by feet. Sometimes it is possible to find a foramen here. Sometimes it is possible to find it is curved left side or to the right side. About the body of the sternum, it is the longest part of the sternum. Look at to the manovarium. If you notice to the manovarium, here it is trapezoid form. The manovarium is visible here. Manovarium is visible here. This external angle is going to join with the body. Manovarium superiorly have a notch. This notch is visible, palpable, find in your body. We call it jugular notch. Supraesternal notch. It is a landmark. In clinic, this is important. Sometimes emergency, critical time is possible. You want to help to a person, for example, in the adult, it is possible you are in the beach outside and you find that something happened here and the respiratory system, the superior part, have problem and the air is not able to pass. So you want to bypass here. This supraesternal notch, this jugular notch help to you. You go superiorly, you go up, make a incision here, access to the trachea. You can perforate the trachea and put a tube here and take this patient to the emergency. Okay, this tube is going to help to air to go and access to the lungs and so help to the brain to get the oxygen. Okay? We call the tracheostomy. This suprajugular notch is important, a landmark in clinic. Now about the manovarium. So superiorly we have suprajugular notch. The suprajugular notch is visible here, or supraesternal notch, jugular notch or supraesternal notch. In each side of the supraesternal notch, in each side you have articular facet. What do you think? You know, which bone is coming to articulate with the sternum here? Clavicle. Make a synovial joint. What's the name of this joint?
Saddle.
Sternoclavicular joint. The name is easy. You use the name of each of the bone. Sternoclavicular joint. It is a synovial joint. Have you ever read about the kind of the synovial joint? Saddle joint. It is a kind of saddle joint. I told today to you to the ball and socket joint, to the hip joint, we have plate joint, saddle joint. Yes, saddle joint is a kind of saddle joint. In your comparative exam, it is possible to ask you which of the following joint is a kind of saddle joint. You should know the sternoclavicular joint is a kind of saddle joint. Now, please pay attention. Inferior to the articular surface of the clavicle, in this side, we are able to show you a completed facet for the costal cartilage of the first rib. The first rib is coming to make joint with the manovarium. We call costo-external joint. Costo-external joint. How many costo-external joints you have? 7 pairs. Only the first one is not synovial. It is a kind of fibrocartilage joint. It is not synovial. It is a kind of fibrocartilage joint. But the rest of the costo-external joint, all of them will be synovial. Look at to the second costal cartilage. The second costal cartilage, the manovarium inferiorly in each side. It is lateral border of the monovelum. Inferiorly, you are able to find the demifascial. Look at here. Inferiorly, you are able to find the demifascial. And here is the body. Body of the sternum. Body of the sternum. Body of the sternum. In each side lateral, you have a demifascial. This demifascial and this demifascial make a complete facet for the second costal cartilage. For the second costal cartilage. Okay? So the sternal angle is a landmark for finding the second costal cartilage with each side. Now we can see the body of the sternum becomes inferiorly. We can find complete facet for the third costal cartilage, complete facet for the fourth costal cartilage, for the fifth costal cartilage, 6 and the 7. Above the 7 we have variation. Above the 7 costal cartilage we have variation. It is possible you find the 7 costal cartilage articulate completely with the body. It is possible a demifascial in lateral border of the body and a demifascial in lateral border of the xiphoid process. Both of them make an articular process for the 7. So the 7 costal cartilage, it is possible articulate only with the body, or such as this picture, articulate with the xiphoid process and with the body. What's the name of this? Because xipho-sternal joint. Xipho-sternal joint, sternal angle joint are in the midline, such as the intervertebral disc. Which kind of the cartilage joint they can be? Symphysis. Symphysis. It is a kind of cartilaginous joint. We call symphysis. All of the costal sternal joint are synovial joint, except
the first one.
first one. It was one of the questions last semester. Which of the, all of the following joint are a kind of synovial joint, except costotransverse. It is synovial joint. Costovertebral, synovial. Costo-sternal, the third one, synovial. Second one, synovial. The first one is not synovial. So pay attention. Which of the ribs is the tallest?
The last rib,
No.
the 7th.
I told you, 7.
Yeah.
7 rib is longer than the other. About the rib also, I finish the rib and then you can have a break. About the rib, we divide to typic and atypic. About the rib, again we divide to 2 groups, typic and atypic. Which of them are typic?
The first 5
Which of them is typic from
Second.
the second
to the
to
8th.
the 9? From the second to the 9. But the first rib, the 10th rib, 11th rib, 12th rib belong to atypic. Why? Because at the head of this rib you have a complete facet. They are going to articulate only with the body of one rib. The first rib, 10th rib, 11th rib, and 12th rib. They are atypical. The second rib, 9 rib, are going to articulate posteriorly with 2 adjacent body of the vertebra. Do you remember the picture that I draw for you? If you look at that, you can find. Now, I should finish the fifth and then you have read. This picture is going to show you a transverse section of the thorax. the natural section is such as this. This is kidney form. Some of the patients, some of the disease are going to change the form and shape of the thorax, such as the rickets. Have you ever heard the rickets?
Yeah.
It is possible make for the cell of the bone make problem. Sometimes it is possible the kyphos change the form of the thorax. Here is funnel chest. Have you ever heard the funnel chest or pigeon chest? Pigeon chest means the sternum convex anterior, more than normal, convex anterior. This picture, look at here, it is a funnel chest. The sternum go inside of the chest. This funnel chest and the pigeon chest, both of them you can repair by the surgery. This funnel chest, it is possible make problem for the organ inside of the thorax. But pigeon chest, only about the cosmetic, this is a pigeon chest. Okay? Nothing happened, only because of the cosmetic, it is possible you want to repair. Both of them with the surgery can be repaired. Here, it is a pigeon chest, before, after the surgery. Okay? Everything become okay. Here you are going to find this picture in the Gray's Anatomy for a student. The kind of the joint. It is going to remember you the fibrous joint. You don't have any movement in the skull. Root of the tips inside of the alveoli is another form of the fibrous. This interosseous membrane between the ulna and the radius is a kind of fibrous joint. Here you are going to look at two cartilaginous joint. Look at to the midline, intervertebral disc, symphysis pubis, and here between the epiphyse and the diaphyse, here you can find the epiphyse plate. It is a kind of cartilaginous joint. And the synovial joint I explained for you, the capsule, synovial, and the articular cartilage and the synovial fluid. Everything I explained for you. The capsule, look at here. You know. And about this picture also I explained for you this morning. Now, look at this picture. In your exam, if I ask you, in your book you have, in your exam, if I ask you, which of the structures are going to form the superior opening of the thorax? Look at the superior opening. Look at the superior opening. Look at the first rib.
The first rib.
First rib and the other rib posteriorly are going to articulate with the vertebral column. And anteriorly, the anterior end of each rib, the level, the position is compared to posteriorly is inferiorly. It is oblique, a slope downward. So in the posteriorly, each rib, posterior end, the position is superior compared to the anterior. Okay? About the second again, superior is posterior end is superior compared to the anterior. It is important. You should know. Now you explain for me the superior opening of the thorax. Which structure, which bone are going to form the superior opening of the thorax?
First rib.
Superior border of the monovarium.
Anteriorly monovarium.
Medial border of the first rib.
First rib. And posteriorly.
And
the first
body of the
vertebrae.
T1. The first rib is atypical rib. Do you know why? Because the posterior end only articulate with the T1. Also, we know the typical rib consists of the external surface, internal surface. superior border,
Inferior border.
inferior border. What the first rib is such as this. Superior surface, inferior surface, lateral border and medial border, such as this. Medial border, lateral border, superior surface and inferior surface. And it curves more. When you are going to compare with the another rib, the first rib curves more than the other. Now, here, costal groove is visible. Inside of the costal groove, you are able to find the neurovascular bundle from superior to inferior. I told you, remember, one vein, artery, and the nerve, intercostal nerve. So they are passing through the costal groove from superior to inferior. This structure you should know exactly. During the respiration, what happened? Look at me. Respiration and expiration. Look at here. What happened?
Diaphragm.
The size, the diameter of the thorax during the inspiration and expiration is going to change. Sometimes during the inspiration it is going to increase. Look at here. During the respiration it is going to decrease. What happened? The size of the thorax anteroposteriorly increase, laterally increase, and the height also increase. What happened that the height increased? It is about of the diaphragm. Diaphragm is dome shape. During the breathing, the diaphragm is going to get flat. So when it is going to get flat, the height of the thorax is going to increase. About the anteroposterior diameter, remember this picture. Remember this picture we call palm handle. In this palm handle, when the handle is here, look at here, the handle is near the stem. When you are going to take off the handle, what happens? The handle is going to go far from the stem. So it is going to happen in the thorax. Remember the sternum, the rib, and the vertebral column. Because when the vertebral column is going to change, the sternum go up and go in front. So at the first, the sternum is near the vertebral column, but during the breathing, the sternum go anteriorly and up. So go far from the vertebral column. To be able to imagine the anteroposterior increasing during the breathing, remember palm handle. To be able to understand and imagine the transverse diameter, remember the handle of this quadrant. Because here, the handle here is near the body of this structure. When you are taking up, the handle go far from the structure, the wall of this quadrant. So the transverse, so when you are breathing, the transverse diameter increase. The anteroposterior diameter increase. And with the contraction of the diaphragm, the height of the thorax also increases. What do you think about this picture? Imagine you are in exam, I put this picture and ask you to explain this picture.
Those muscles during when we breathe, they pull the rib up to increase the size of the thorax.
Okay, you, Mama.
During the breathing, it's gonna to when that muscle
Contracts.
during concentration.
If you want to become a good doctor, you should pay attention to everything. Ladies, this is easy. You are going to look at something wrong in this picture.
Lifts up the sternum.
No. Consult to this patient. A lot of doctor wanted to find the problem. If it is wrong, it's not matter. Tell me. What do you think? Tell me. Let us speak right. Go ahead. Okay. I explain for you.
What was the question?
What do you think of that picture? Just that.
No. Not please.
Because of this artery.
No. This artery okay. Why this artery has problem?
Yeah, because
Oh, because the artery has a problem because this muscle it contracts and pulls up the thorax and during breathing.
it's a syndrome. I
Where did you
read about that.
where did you just change?
No, this morning I explained for you.
Yeah, it's a syndrome.
Do you remember the coastal element?
Yes.
C7 in this patient, C7, the coastal element developed, grew, and made the cervical rib. It is the first rib, okay? It is a cervical rib. Normally, cervical rib is never found. Sometimes the cervical rib in proximal part is bony structure and in the distal part it is a dense connective tissue. Sometimes in all length the cervical rib is going to get and change to the bone. This bone is coming down and attached to the first rib, so the subclavian artery and this muscle is coming to attach to the first rib. This subclavian artery is going to compress here. Do you remember I told you it is possible the brachial plexus with the cervical rib make problem? Now it is possible the artery, the vein gets problem. So be careful. It is possible you find a picture, a radiography that the patient has the cervical rib and the cervical rib is such as this form. In the radiography, only you find the proximal part of the bone. Here in the radiography is not going to be appear. But you should know that this fibrous also can make problem for the subclavian, for the brachial plexus problem. It is again in one side the cervical rib. And okay, so what's the time?
2:34.
A break.